Hello, how are you doing? This is a presentation that I gave to the Minnesota Physician Patient Alliance on May 16th at their regular meeting, attended by several physicians and others interested in the whole healthcare question. I call it Treating U.S. Medical Care's Sick Patient. It's really about reference-based pricing, but I'll get to that. If we look at the current situation with healthcare in the United States, I think we could say that it is suffering maybe a terminal disease. It certainly suffers from multimorbidities. Dr. Plotnikoff here in the Twin Cities taught me that term in a great talk he gave about how so many patients present with one major problem, but underlying that, or maybe several major and minor problems, but underlying that are many problems. And if you don't treat all of them, you can't really bring that patient to the healthiest state. And so he's been blessed with this opportunity to have a practice where he has the time and the resources, the interest, and so forth to treat multimorbidities. That what a wonderful way to practice medicine. Anyway, I look at our healthcare system in the United States as not suffering from just one major problem, as some will say. Actually, if you look at the way that the Affordable Care Act was put together, when they talked about access, quality, and cost, they didn't function, or they didn't focus on quality, and they didn't focus on cost. They focused on access, and they said if we could reduce the uninsured rate, then we'll have solved this great problem for the United States. Well, you can't do that. As many doctors have said, you could have access, quality, or cost, choose any two. Trying to find a way to do this that will actually treat all three of those morbidities, if you will, is the key thing. But way beyond that, this list that I put up here is just a partial list of the real problems that are facing healthcare today. And some of them, many of them, are caused by government interference or by overregulation or managed care or on and on, by the culture that we live in, by lifestyle, and so many other things that affect how in the world we can ever bring some sort of healing to this system. But the one thing that we hear more and more often, actually before the Affordable Care Act, we didn't hear this as often. We heard more about access, but now it's about cost. It's about cost. It just costs too much. When you have insured families having to pay $1,200 or $1,300 or $1,500 or $3,000 a month for a terrible high deductible health insurance plan, it's just too expensive. And it's come to a point where private health insurance is being priced out of the market, and we're being threatened then with the healing, if you will, of Medicare for All or Medicare for America as the alternative. And so our goal, we formed a group called Minnesota Employees and Employers. I think I got that backwards. Minnesota Employers and Employees Demanding Affordable Health Care. Our mission statement is very simple: to reduce the price of care, to reduce the, actually we use the word cost. I prefer the word price. And we see that there are at least two different forces, if not more, trying to mitigate the price of care. One is institutional forces that you're all too well aware of, and that's government and politicians interfering, if you will, imposing their will on the medical industrial complex, trying to tame it or make it conform to some highfalutin ideas of economic conformity that just don't work because human beings don't participate in making rational decisions all the time. So we have institutional forces, third-party payers and managed care, and the media even joining the fray, academia, professional associations, all these institutional forces trying to reduce the price of care, or maybe hiding the fact they don't really care to reduce it. In some cases, they like it higher. On the other side, we have what we call patient power. In fact, that's the name of a very famous book, as you all are aware, a great book from 1972 by John Goodman and others, Patient Power. in which we recommended and then won the right to health savings accounts and using health reimbursement arrangements and patient-directed health plans. The term we used was consumer-directed health plans, and I've tried to change that term with people that I influence. Patients are not consumers in the technical sense we think of consuming other products and services. They do consume medical products, they do consume medical services, but let's use the term patient-directed health plans and patient responsibility, ways to put the patient in some way involved in paying the cost of their care and making decisions for themselves. That's a great way to reduce healthcare prices. We know that we have to reform health insurance laws to reduce premiums. It's absolutely necessary. The way the laws are construed now, with so many ripple effects that have driven up the cost of insurance way beyond affordability, we have to reform those laws. There's no question. But one of the things that has emerged certainly in the last several years here in Minnesota in particular, when we passed a transparency law last year, which I'll discuss a little bit later in some more detail, we passed a transparency law that required the disclosure of prices of care. All of this in the name of trying to reduce the price of care and making patients somewhat aware of what they were spending for care, as if they cared, depending on their health plan. Now, I'm going to make a little bit of a move away from that for a second and then come back to it. I wanted to talk about 4 recent reports that I've studied and reported on that have to do with hospital price spreads. And by price spreads, I'm talking about the difference between what Medicare allows and what private commercial insurance or private parties actually pay for health care. The Minnesota Community Measurement Group studied this. The Congressional Budget Office just released a report on it. I'm going to share these 2 and then briefly, and then 2 others, and to give you a feel for what we're talking about here. For private pay patients, according to Minnesota Community Measurement, private pay patients, hospitals accepted 187% of Medicare as full payment. Let me explain the term accepted. What we're saying by this and what Minnesota Community Measurement is saying is when you look at the actual price that the hospitals would accept as full payment, it's not what they billed. And they billed quite a bit more. In fact, they could have billed 250% more, 300% more, even more than that. We actually have found some as high as 20 times the Medicare rate, seriously. So we're not talking about the billed rate here. We're talking about what they actually accepted as full payment, 187% of Medicare's allowable amount. The Congressional Budget Office, in a report just released this month, May of 2019, found in their study that hospitals accepted 189% of Medicare as full payment. Comparing these 2, 187, 189, it sounds like perhaps we're onto something here that, my partner and I write about this as a hidden tax, by the way, because we know, and I know this is offensive to the great sensibilities of many of you really, really smart doctors who know that this is a play on words, and that's all it is. It's a play on words. But we're trying to explain to patients that for something that Medicare pays $1, they have to pay $1.89. And it's almost like a tax because they have to, in a way, they have to support the underpayments of Medicare by paying more in the private system. Believe me, we're not recommending that we go to a Medicare reimbursement scale for everything. This is just pointing out a fact. So anyway, the RAND Corporation just released their second study on Medicare spread. And they evaluated employer data for about 250,000 employees. And I can't remember the volume. I think it was $13 billion in spending. They crunched all the data and they adjusted. And by the way, The numbers I'm showing you here do not include the professional fees paid to physicians and to other medical professionals. This is facility fees. So just to be really clear, this is facility fees. So they found across all these states, for inpatient care, hospitals accepted 204% of Medicare as full payment. For outpatient care, hospitals accepted 293% of Medicare as full payment. That to me is very instructional, because we are seeing in the cash payment area such groups as the Oklahoma Medical Center, run by Dr. Keith Smith, that charges way below the billed rates. They're still charging more than Medicare would allow, but they're discounting a great percentage off of the bills that other outpatient centers are charging. I don't know what it should be. I don't know what their number is. I'm just saying the RAND Corporation found that outpatient services, hospital outpatient services, were making 293% on private pay patients above of Medicare. The average hospitals accepted, if you take inpatient and outpatient, and I hope I don't get this all jumbled because it can get confusing, but I hope it makes a lot of sense. The average was 241% between these two. So what this means is that if an individual went in and spent $1,000 on, or an individual on Medicare had a procedure for which Medicare allowed $1,000. Remember, this isn't what they pay because they only pay 80%, but allows $1,000. That private pay patients on average were paying $2,410 for that same service. That's what that means. Now, the state of Montana, which was charged by their legislature on their employee plan, it covered 12,000 state employees, 31,000 lives, faced a $9 million deficit. And instead of forcing the employees to ante up more or cut back their benefits, the legislature ordered the commissioner in the state, and I believe it was the insurance commissioner, commerce commissioner in the state of Montana, to find a way to save money because they faced a $9 million deficit. And in doing this, Montana decided to go to a reference-based price system. And so in their studies, they discovered that the hospitals in Montana were accepting more than 350% of Medicare as full payment, not 241% like what RAND Corporation found. In fact, in the RAND study, they show tables that include Montana, and there were hospitals that were closer to 400% what they were accepting as full payment. So what Montana did then was decide they were going to go to these reference-based plans, and they were able to average 234% of Medicare as full payment to get the hospitals to agree with that. Now, how do I know all this? I interviewed the person who put this contract in place, very knowledgeable, and she explained all the fights they had and how even they had to get the employees involved, the union involved, to bring pressure on the hospitals to agree to these payment rates. Or the state employees weren't going to have hospital access in some areas close to where they live. And the unions did this because their choice was to get the hospitals to finally agree to this, or the union employees were going to have more of their payroll taken as a benefit, as a health benefit, and get less on the check. Or they were going to have their benefits cut because they were under orders to balance this thing. So this is what they ended up negotiating. They also discovered that physicians, remember I told you, the fees that RAND was reporting are separate from professional fees. So in Montana, they found that physicians are accepting 165% as full payment. Now, if you're a physician and you're looking at this can help you kind of calculate if you were to have a reference-based price plan, You might not choose 165%. I'm going to give you some examples. You might choose a different rate, but at least it gives you kind of an idea, at least in the state of Montana. So let's talk about what a reference-based price health plan is. Some call them Medicare Plus. This is Dave Racer definition. I didn't pull this out of a book, but best I can figure it out. Setting the price of medical care at a percentage of a common price in any given locality. So the common price could be whatever my friend Dr. Plotnikoff charges for an intake exam. I mean, that could be a common price, and everybody could charge a percentage of that. But of course, that would be really chaotic. So we need something that is a little more ubiquitous. And Medicare's allowable reimbursement is the most ubiquitous price. There is a Medicare allowed price for just about everything. Now, we're not saying here that you accept Medicare. That's not the point. The point is you have to have a common price that everybody can relate to and can identify with, over which they really have no control, because Medicare sets these. I got to ask the question at the meeting, how does Medicare determine this? That's not for me to go into in this presentation. It's an interesting discussion. What's important is that there has to be a reference price. Medicare is the most common. It's everywhere. It's adjusted for local cost, at least to some extent, and it gets adjusted every year. Every year there's a slight increase, pretty much, I guess. So it's a price everybody can relate to. That's the whole point. Yes, you still have to use codes and DRGs and other things to get to the Medicare price. But price is not the right word. It's a Medicare allowance. So with reference-based pricing, health plans, Medicare's allowance is the reference price. And then, now I'm talking in theory here, the way it should work. Medical professionals and facilities establish their own price. Nobody tells them what they get to charge. They decide what price of Medicare they're going to charge. And the prices are expressed as a percentage of Medicare's allowable price, and they're made transparent so that a patient could actually call a facility, or they could call a physician and they could say, what percent of Medicare do you accept as full payment? And they could call several and get the percentage of Medicare that each of them do. So let's take 4 examples. I made these up. These numbers are just for example's sake. Let's say St. Paul Regional Hospital decides that they will accept not 204% or not 293%, but for everything, they'll accept 200% of Medicare. And they earn a 5-star rating doing so. And Minneapolis Regional found ways to cut costs. They don't have the piano in the lobby or the waterfalls, and maybe they use 2 to 4 patients in a room, but they find a way to save money. And so they accept 150% of Medicare, and to get a 4.5-star rating. Now, in the RAND study, we found some that were at 150% reported on that had 5-star ratings or 4-star ratings. So the price didn't necessarily relate to the star rating. So let's say in Southeast Regional Minnesota, the hospital there accepts 325% of Medicare, has a 5-star rating all over the world. I'm not naming names here, but there's really no competition there, where in St. Paul and Minneapolis, there's more competition. In Northwest Regional, which is in greater Minnesota, has less competition and more expense perhaps, or less expense, but they're able to accept 265% of Medicare, and they get a 4-star rating. Okay, so these are 4 examples of what you might see in a reference-based price pricing system. And by the way, when we talk about how to price healthcare, we are taught that insurance companies discount a certain amount down to what they actually accept. That isn't really what happens. What happens is they mark up from Medicare. They pay a percentage above the Medicare unit rate. That's how they figure it out. They don't figure it out by discounting every single service that you offer, by CPT code. If they charge 100 for this and 12 for that and so on, we're going to discount, 60 or 20, whatever it is, 27, 30% or whatever. I actually have a number. I'll share it with you a little later. What they do is they have a percentage above Medicare that they negotiate in the contract. That's the way it really works. So let's take 4 physicians. Dr. East over on the east side has decided that she can run her practice at 150% of Medicare. Dr. West accepts 165% of Medicare. Dr. Edina has a fancier clinic, perhaps, has a wealthier clientele than the downtown St. Paul guy, and so is able to, and really has a great reputation, by the way. People will drive 30 or 40 or 50 miles to go to this doctor. Is highly in demand and can charge more. And that's Dr. Edina's business. And Dr. Midway accepts 200% of Medicare, has a really good clinic, really good reputation, has been around for 40 years, and is doing all the new procedures that people are willing to spend a little more. That's how it works. But the key thing here is they decide what those rates are going to be. No one else decides that for them. And so the reference-based pricing plan works like this, that it pays at a percentage of Medicare. The plan designs can vary just like any standard plan today. You could have low deductible, high deductible, in between deductible, HSA, if it was allowed by law, HSA compliance plans. You could have co-pays and co-insurance. I mean, all that stuff can still be there. But we're talking about how to determine how much the plan will actually pay. So they're still held captive to total claims. It's claims that drive the price of healthcare, and the more we spend, the more the premium is going to be affected by that. If we spend less, the premium will go down, theoretically. So any health insurance policy is held captive to claims. These plans resemble, in a way, the old indemnity plans, or even the new ones, by the way, because there's a lot of new ones coming along now that pay a fixed fee, so much a day for hospitals, so much a day for, or so much for a visit to a doctor, exam, and so forth. It resembles those, but instead of having a dollar amount, they pay a Medicare plus rate. So the individual buys insurance that sets the payment at a maximum percentage of Medicare. And I'll explain that with some examples in a second. The individual decides the rate within boundaries. I mean, they're not going to say, well, I want 153.76% rate. There'll be steps, 140, 150, 160, and so forth. But any amount above the rate that they choose, they are personally liable for that. And they could have a different rate, as we've learned from the RAND studies and from Montana's experience. There could be a different rate for professional services and facility charges. And by the way, someone asked the question about, providing care in a facility and then charging a facility rate plus the professional charge. There's legislation dealing with that. I know in Minnesota and probably elsewhere, maybe it was even in the federal law. I'm a little foggy on that, but where we're trying to stop that practice. That's not related to this at all. Really isn't. So let's say that one person buys Plan A. It allows up to 150% for physician fees and up to 200% for facility fees. So this means that the patient will search for a physician who will accept as full payment 150% of Medicare. And if the physician wants 200% or 250%, that's fine. The individual then has choices, and we'll talk about that in a second, what some of those choices could be. Another plan maybe allows up to 170% for physicians' fees and 225% for facility fees. And Plan C is a flat one. It just allows 200% for physician or facility fees. Well, what if the physician's real fee is only 165%, as they found in Montana? Well, then the plan will pay 165% because it's an up to. You wouldn't want the physician padding the bill because he or she knows that they can get more. And then Plan D, let's say, is a real cut rate plan, 120% for physician fees and 175% for facility fees. The individual makes the decision. The health plan offers the options. So someone who bought a 120% plan, Plan D, is going to pay less in premium than someone who buys Plan B, for instance, or Plan C. They're going to pay more. Or Plan D is going to pay less, I should say. Plan C will pay more. So that should be clear because the percentage of Medicare it's going to pay is less. But that means the patient is going to have to pay the overage. So the patient is taking the risk here that that they're not going to have to spend a lot, or they're going to try to negotiate with the doctor to get a better rate. So the ideal plan allows balanced billing and direct negotiation with the patient. So take Plan A. I go to my friend Dr. Beecher for psychiatric evaluation. His fee happens to be 200% of Medicare. I only, my insurance plan will only pay up to 150%. And so then Dr. Beecher and I have a discussion about that extra 50%. Is he going to demand it? Well, if he's as good as everybody says he is, and I think he is, then I'm going to willingly come up with that out of my pocket and pay for that extra. If I don't think he's worth it, he might say, well, look, for you, I'll go to 175%, or even 150% because I see that's all you have. It's up to the doctor. It's up to the individual to decide how that works. Or maybe I go find a different psychiatrist who's willing to work for less, but maybe isn't going to produce as good a results. Those are the kinds of things that consumers do when they consider things. Now, right away, a physician said to me last night, well, why do I have to file all this? Well, I think one of the reasons physicians have been willing to file claims and get paid by the insurance company is because they have a better chance of getting paid than billing the individual, or maybe they think they have a better chance, or it's been so long since they've had to deal with 100% payment coming from patients, they just don't know if they trust it. But that's a physician option under a reference-based plan. The physician can say, no, I'm not going to file the insurance claim for you. Here's a receipt, pay by credit card, and you'll be able to get reimbursed under your plan. That's frankly the cleanest way to do it, and it has the most advantages in terms of reducing overhead and so forth. So essentially, that's how reference-based plans pay and are designed to work. The plan designs can vary. They pay a percentage of Medicare up to a certain amount, maximum above which the doctor can negotiate, or, but you got to make sure there's no balance bill provision in this. This is not Medicare. It's not under Medicare's rules. The prohibition in Medicare for balance billing does not apply. Why? Because all we do is use the price as a reference. Now, there may be legislation that has to be passed, and in fact, in Minnesota, there's a bill in the hopper already that we helped draft that we hope is going to go up next year that allows reference-based pricing for fully insured plans. These are coming on self-insured plans right now. So why would a physician really want to embrace this? Well, first of all, there's no networks. There's no networks. Any willing physician who will accept Medicare Plus as payment can participate. There's no multiple reimbursement schedules. You don't have 40 or 50 different contracts, network contracts with different prices, and trying to figure out which plan your patient is in and get the filing done right. It doesn't exist. You can accept cash payment or insurance reimbursement. You can work that out, improve your physician-patient relationship because you're less hindered by managed care, so you can practice medical care, not managed care. Of course, the plans are going to have some review. I mean, that's if they're going to pay, they're not going to just let willy-nilly, physicians spend the money. You know how that works, but at least it's not going to be the overbearing managed care that you're used to today. More time with patients, less time checking off boxes. More time for multimorbidity cases, again, mentioning Dr. Plotnikoff and his wonderful practice. Wouldn't it be wonderful for you, Mr. Physician, if you actually had the time to spend with a patient and explore all those things that are going on with that patient to help solve their medical issues? Reduced overheads because you don't have to have as much support staff. Gaining control of your own work schedule. Competing with other physicians to provide medical care, differentiating yourself, because guess what? If the patient can call another clinic and say, what percentage of Medicare do you charge? Well, then you can do it too. And you can find out that Dr. A is charging 175% and you're getting 150%. And you know you're better than Dr. A, or the other way around. And you want to take some of his business, and so you charge 165%. Just like, now I don't mean to demean you at all, but I used to say this about gas stations on four corners. You know, if you know the price of the four physicians on the four corners, and then you knew something about their quality and their patients and so forth, you might choose based on price at that point. And you can compete on price. Okay, reduce stress, less burnout. We read the book Slow Medicine this year by Veronica Sweet, and what a wonderful book it is. That for a non-physician, I just really enjoyed reading about what it was like to practice medicine, as maybe you all conceived it when you became doctors at the beginning. This plan would allow for the practice of slow medicine when it's necessary, and fast medicine when it really has to be. So this is what I presented last night, but what hangs over all this discussion? I mean, come on, let's be honest. Right now, the push is for Medicare for all, Medicare for America. Some would suggest that the Affordable Care Act was designed that way to fail, and everybody knew it was coming. At some point, it would just break down, and the prices have gotten so outrageous, and you hear all these proposals now, and we might be, a year off, or 2 years off, or 10 years off. But if the political winds change in Minnesota, it's very likely that Minnesota OneCare will pass, and or that we'll get a Medicare for all plan. The Minnesota OneCare literally has the state competing as an insurance company with the insurance companies and paying a reimbursement rate between Medicare and Medicaid or somewhere in there, but it's not Medicare plus. That's the point. And then you're forced into this if you want to continue to practice medicine with a Medicare rate for all. So I'm not saying that as a threat. I'm just saying consider, if you will, that the Medicare Plus plans, reference-based price plans, might be a great alternative. I appreciate your time. Feel free to contact us at any time about this. You have a great day, and I wish you well. Heal, everyone.